As we have developed more and more classes of agents for type 2 diabetes, and we now have 12 classes of agents. It's amazing how many classes of drugs we have for this disease entity. It has become easier for us to customize the treatment to the individual patient. And there's some very general and obvious things like, is the patient just maybe normal weight, or maybe mildly to moderately obese, or maybe severely obese? Does the patient have hypertension? Has the patient had a prior cardiovascular event, or are they at unusually high risk of a cardiovascular event? What's happening in terms of their renal function? All these things are important background questions for the next question, which is, how do I best individualize treatment for this particular patient? And it's a very complicated question. I don't think we have time to go into this in full detail, but suffice it to say that if we look at the different elements of the pathophysiology of type 2 diabetes, and we have this term, the ominous octet, where we have at least 8 different organs or maybe cell types within an organ that are involved in the pathophysiology of type 2 diabetes, thinking about what may be most relevant in that patient, and then trying to target the diabetes treatment at those particular organs or those particular causes, I think is helpful. Now, that being said, most of our diabetes agents will address more than one of those organ systems or cell types. So it's not a clean situation where this patient with diabetes, the only problem here is excess retention of glucose, therefore I'm going to go with an SGLT2 inhibitor, or this patient has just insulin resistance, therefore I'm going to treat with pioglitazone. It's not quite to that degree, but the concept of understanding the situation of the patient in general, trying to look at those individual organs or cell types that are involved in that patient, and then trying to have the treatment target those, I think that's all appropriate, all important. One other thing that we always deal with, of course, as clinicians, is the question of insurance coverage. And like it or not, that's a part of the equation. So if we have generic products, we try to use those first. We look at the patient's insurance coverage. Hopefully they have that. What are the preferred either classes or agents within a class? That's all part of the individualization of the treatment. And I think if we can address this and have the time to address it, as in our busy practices as we see these patients, we really have the tools now, the information and the tools to customize to the patient's needs. And we can hopefully get the best glycemic control, the best reduction in cardiovascular disease risk, prevention of first or future or recurrent cardiovascular events. We can have the best method of addressing kidneys, hypertension, obesity, other elements that are part of this story of type 2 diabetes. And it's an exciting time where we can do all of this, also with an eye to the cost for the patient, the out-of-pocket cost, even perhaps the cost to the system or to society. So very complicated, but also very exciting that we have so many different ways of understanding the individual patient and their own type of diabetes that they have. And it's type 2, but it's different types, subtypes, and then the way that we can appropriately treat this.